Sounds great. It sounds great. Thank you so much for the introduction and invitation to speak at this conference. As I was looking at the agenda and the folks who are attending, a lot of you have been very influential in sort of making my research better and more efficient. So I thank you, for the invitation and the chance for me to very humbly speak to you today. Which I'll talk about. I think we're at a ripe time, given the number of tools out there, particularly the tidyverse and our studio, to navigate the sea of associations that emerge from observational biomedical big data. So what do I mean by observational big data? It's the data that many of you are probably using, for example, for post surveillance of drugs, for example. And these big data for example, they emerge from electronic health records, claims data sets, biobanks, and they're convenient samples that are providing a way to study biomedical phenomena at scale. And so, for example, an example I gave earlier is like trying to look at drugs and their adverse events, potentially genetics and their association with disease, and looking at the combination of both genetics and social determinants of health, for example. And here's an example that we recently published a couple of years ago that I'd like to show off to you. But that's not really the subject of my talk today. It's how we can use these data sets better to make correct inferences. And they have been available to us to provide timely biomedical questions to address them. So here's an example that just came out in April of this year using these real world data in the setting of Israel, where 60% of individuals who are subscribing to a singular healthcare plan, by which we can understand in the real world how our vaccination was doing in individuals who are unvaccinated versus vaccinated. And so a nice confirmatory study in the real world to see of individuals who are vaccinated versus unvaccinated, what complications do individuals face due to the intervention and those who are not intervened on. But these data sets to use them, it's an art, okay? They require a lot of massive amount of data decision making and assumptions before getting to the answer. And so I reiterate, it was a beautiful study, and it was able to answer a question, but you can understand the number of decisions that need to be made. So, for example, in the tidyverse lingo, you take your big data set, you filter it in many different ways, as shown here on the left-hand side. Then you have to have some inclusion and exclusion criteria. Then you have to have a method to match individuals who are vaccinated to unvaccinated, which you could use gold standard causal inference methods to match individuals. And then finally, to associate individuals with the exposure and their chronic or complications. So there's a lot of decisions that we need to make that could influence the findings that we have. So what if we don't filter and exclude and include correctly? Here's an example, one of my favorites from Dennis Agneal and colleagues in BMJ in 2018. Asking a very naive question, but an interesting one, is white blood cell count associated with death. And what they go on to show is that due to how the health data is collected in these convenience samples, you'll get very biased estimates. So here they're showing for individuals who are sampled, who happen to be normal. They happen to be sampled between hours of 6 a.m. and 12 a.m. But the individuals who have the lowest survival rate are being sampled for their lab data early in the morning. So you can kind of intuit this, right? Like, for example, individuals who are very at risk for death in the population are going to be sampled at early times of the day, potentially outside of the workday, the usual workday. During the weekends, for example, and being more highly sampled. So you want to monitor the individuals who are at very high risk for death. So if I were to ask this very naive question, it really matters on how we sample these individuals. And things like how and when a patient gets a test is often associated with death. It's not the test itself. So this is an example of a bias known as healthcare systems dynamics. What if you don't match correctly? What if you don't do your associations, quote unquote, correctly? For example, are all the drugs that we take associated with cancer? Here's a paper we published a few years ago where we associated all the drugs that are prescribed in the entire population of Sweden with time to cancer. And you could just imagine, without looking at my results slide, that we found a huge swath of associations, just given the power that we had, over 9 million individuals. And we also looked at two modeling techniques and found vastly different results between the two. So here's an example of the, sort of our mainline findings. On the x-axis here are the negative log 10 p-values for these associations, for example, for the Cox time to death. On the y-axis here are different categories of drugs. And what I like you to appreciate is that you have associations that have very, very low p-values, or we have associations that are crawling up there. It seems like everything is correlated with everything, and that are too many to be plausible. So for example, if you ask the question, how many of these drugs that were associated with any cancer, 26%, up to 10, 7, and 3% respectively for prostate, breast, and colon cancer. And there's a modest concordance between the methods that you might choose between Cox and case crossover, for example. Only 12 out of the 141 associations that we found in Cox were able to be also found in case crossover. So, and the correlations were small. And so this is indicative of things like a residual confounding and other sorts of biases. So in these large biomedical observational convenience samples, we have a lot of ways to associate our different interventions with outcomes. And these mazes of associations, as Stan Young has said, could lead to a vibration of effects. And so, for example, you're modeling a system, you might not know what to match for ultimately. So you do a univariate model, it might not be significant, and you start putting in things in the model that you might think are, be correlated with both your exposure and your outcome. And all of a sudden you have a significant result. So which one is true, which one's false? It really depends on your a priori hypotheses, which are sometimes arbitrary. Most of the time, I would argue they're arbitrary. These mazes of associations could lead to a vibration of effects, and how that affects our decision-making in the end is very critical to understand. So what do I mean by that? So the assumptions that we make to filter are, to have inclusion-exclusion criteria, how we ultimately match. How do we better navigate all these assumptions that we're making across study design choices in these large data sets? And I think this is where Tidyverse can help out, because we can test all assumptions systematically and see which ones survive. It's the idea we've been testing out. So we call it the vibration of effects, where we take a data set, particularly an association of interest. So for example, maybe vitamin D in death or white blood cell count in death, and just look at the assumptions we might make, for example, in the models that we might adjust for, and see how the associations manifest, and plot them in this association size versus the negative log 10 p-value here, to get the distribution of associations under different study design choices. And so here on the left-hand side and the right-hand side, we showed two different patterns of association. Here's vitamin D associated with death and thyroxine associated with death on the right-hand side. And you can see here what we're trying to display is how your associations change as a function of number of covariates in your model. And on the black line here is a Bonferroni level of significance for the number of tests that we're doing ultimately in the data. And so what you see is that you have a attenuation for things like vitamin D and thyroxine, some of which might make your significance level, significance of the association go down below your statistical significance threshold. You might see things that shift the effect size distribution due to different adjustment sizes. So here's an example of cadmium when you adjust and not adjust for current smoking on the right-hand side. So the black points are when you do adjust, and when you do not adjust, and the white and the yellow points are when you do adjust. So you see this gross attenuation, but overall the hazard ratios seem to be on the right side of 1, or the null. But what we're really concerned about is that if you have an association that, depending on how you adjust in the model, you have things that might be significant or insignificant at your arbitrary p-value threshold, but that also might indicate a risk or protection for a particular outcome. So here is alpha tocopherol, a type of vitamin E, that depending on the assumptions you make, your study designs, you might have associations that go on either side of the null. And we like to call this the two-phase risk profile, or the Janus effect. So the risk and significance, of course, as you all know, depends on your modeling scenario. We're trying to make this more systematic in packages that more systematic in our packages. For example, here is something from our group in which we try to make this more automated to leverage the multiple associations you might make in your regression model. Here's a couple more examples. I'd say that these types of analyses are kind of like a multiverse analysis. So put forth by Sarah Stiga, Andrew Gelman, and others in the field. And so automating this degrees of freedom in your associations, I think, is a ripe area of interest for individuals. Here's another famous example: many analysts looking at one data set to see how different approaches in your analyses might lead to different results, different associations. How do you combine? How do you make inferences across these? Is, I think, is where we need to go. So in conclusion here, observational big data provide a lot of degrees of freedom, and I think it's up to us to provide standards by which to analyze these. And I think the vibration of effects idea provides a compass to not properly navigate the sea of possible conclusions and decisions that we might make. And with that, happy to take your questions in the chat, and thank you again for the opportunity to talk to you today about observational big data.